Let's get 2 minutes on the clock and your time starts now. All right, time is up. And if we want to be looking into things, and you'll probably notice a little bit of overlap between one of the earlier questions as well, what are the things that can mimic these kinds of episodes or induce them, or basically what are the things that we want to be excluding when we're talking about what seems to be at first glance panic attacks? So the big things you wouldn't want to miss would be cardiac arrhythmia. So paroxysmal AF would be rare but not impossible. I'd be thinking more along the lines of things like Wolff, Parkinson, White, or supraventricular tachycardia. So I think having that is probably going to get you 2 marks there. Pheochromocytoma, particularly with that sense of impending doom, is one of the things that very rare, unlikely to be the case, but would be one of the things that you want to exclude as part of a workup here. Acute myocardial infarction, unlikely in someone so young, no other significant medical history, but would be something that would be, again, worth investigating, and you're going to get some overlap between your investigations for your cardiac arrhythmia and myocardial infarction. You'd certainly be doing a lot more kind of questioning and examination to try and rule in or rule out that one, but keep that in your memory bank. Hypothyroidism. You'll see that come up again and again, and for most questions in the KFP, you can sneak it in there somewhere. It's the great mimic. Poorly controlled asthma. We could actually be seeing exacerbations of asthma causing these symptoms here with palpitation, sweating, trembling. And tied into that as well, I'll skip on ahead a little bit, hypoglycemia. These can all be symptoms of hypoglycemia, so would be worth investigating further. Now, epilepsy, these could be partial seizures, and so again, you'd be wanting to explore and tease out a few more details about the presentation, as well as things like Addison's disease. So again, one of the great mimics can easily be missed if you're not actively looking for it, and so teasing out a few more questions there. Now, tied into kind of the epilepsy and epileptiform type disorders, be looking into things like your TIAs or potentially CVAs as well. And I have seen a case not too dissimilar to this exact story that was actually serial TIAs from a patent frame in Ovale tying in some of our cardiac investigations. And so is something that you definitely don't want to miss. And of course, intracranial lesion or infection, less likely to be the case with this time frame, but lesion could be a potential thing here. Again, something you wouldn't want to miss and you would be wanting to tease out further. All right, hopefully you've got a few answers in there as well. Again, you'll notice there's lots more answers here than there are things that have been requested, which means that as long as you're putting down sensible things along these kinds of trains of thought, you should be getting some marks. All right. Next question. Let's get 2 minutes on the clock and your time starts now. All right, time is up. And I have been a little bit mean with this question, admittedly. But I wanted to focus in, you're more likely to get things like depression, anxiety, but any condition is fair game, and so there would be a basic familiarity with DSM diagnostic criteria. And part of this as well, if you look at a lot of the Medicare or PBS, billing criteria, they need specific diagnoses. And so you need to be able to say with medical certainty that this patient meets this diagnosis. So the DSM criteria for panic disorder would be recurrent unexplained panic attacks. Now, in the criteria itself, it does go through to list different symptoms of these panic attacks, but I think as long as you're saying these recurrent unexpected panic attacks, you're getting 2 marks there. Just recurrent panic attacks, you'd probably get 1 mark. It's the unexpected qualifier that I think adds that extra little bit of knowledge base there. At least one of the panic attacks has been followed by 1 month of persistent concern or worry about additional panic attacks is the second major criteria there. And a hint, if you ever get these questions, DSM will pretty much always have the disturbance is not attributed to the psychological effects of a substance, and the disturbance is not better explained by another disorder. And so you're not going to get as many marks, but if you're really struggling and aren't sure what else to put, there's a few free qualifiers in there for you. All right, hopefully you have done well there. And I would be familiar, just passingly familiar with the diagnostic criteria for your things like major depression, anxiety disorder, and know what kind of ballpark things you would be placing or looking out for to meet some of these diagnoses here. I would say probably also be familiar with bipolar disorder as well, 1 and 2. But for now, let's get 2 minutes on the clock, and your time starts now. All right, so every now and then you get those questions where you're like, okay, I've got a feel for what's going on here. I think I know which direction this is going. And then they just seem to pull the handbrake and do a quick U-turn on you. And look, you've absolutely smashed it there. We are looking at imiquimod topical therapy or podophyllitoxin topical therapy. You can also use cryotherapy, which is good if there's just a few lesions. Can be quite uncomfortable given the anatomical location, but would be something that I would offer as well. Now, we have specified here, of course, that doses are not required. I think you probably would get perhaps more marks or show that extra little bit of polish if you do know the imiquimod's 5% cream or the podophyllitoxin's 0.5% paint. But I think if you just pop down the imiquimod or podophyllitoxin, I think you're going to get at least 1 mark there, so you should be pretty safe. Of course, this is taken from ETG as the gold standard source for these kinds of questions. Now, if this is something that you're not familiar with, and I know speaking to others, if you're perhaps a female practitioner that don't see as many males, particularly about genital things, this can be something you might need to familiarise yourself. Females can get genital warts as well, but certainly I think that it's, in my experience at least, being a male GP, I've seen many more male patients presenting with genital warts than I have female patients. So knowing what your target demographic is and how to best treat them is, I think, very, very important.